Okay, so we're gonna get started. It's 2:01. And I like to my counterpart, Chair Vital, and we do a lot of things together. I like her to start us off and say a few words, and then I will go ahead and introduce the agenda.
Thank you, Chair Melnick. I just am happy to see so many people join us. This is such an important issue. And while we don't know everything, I think as we go along, we're learning more and more about how the changes in the federal government are going to impact our healthcare. So thank you, Chair, for putting this together. And I look forward to hearing from you.
Thank you. And I want to say good afternoon and welcome to everyone. This is a virtual meeting, and it is actually a joint briefing with the Senate Finance Committee and the Health and Government Operations Committee on the impact of the Federal Reconciliation Bill on the Affordable Care Act in Maryland. And we're going to actually hear from the Maryland Insurance Administration, the Maryland Health Benefit Exchange, and the chief actuary for the Maryland Insurance Administration. This is an important issue, as Chair Vital just stated. As you know, the Maryland General Assembly, the House and the Senate have worked really hard to anticipate what the changes are at the federal level to make sure that we protect Marylanders. We have been able to codify many of the provisions of the ACA into Maryland law. We have reduced the uninsured rate since we expanded Medicaid and we created the exchange by more than 50%. Our uninsured rate went from 14% to 6% where it is now. It is people in all 24 jurisdictions that are now covered. So it does work. So we do have some challenges with this new federal administration, and today we're going to discuss the implications to Maryland. So first, we're going to hear from Johanna Fabian Marks, who's the Director of Policy and Plan Management for the Maryland Health Benefit Exchange. Johanna.
Thank you, Chair Peña-Melnyk, Chair Vital, and members of the committees for the opportunity to brief you today on this, certainly very timely and fast-moving. So we've all been scrambling to understand these proposals and their impact, and everything is still in progress, but this is kind of our best understanding as of the moment. We can go on to the next slide. So I'm going to give an overview of the provisions in the House Reconciliation Bill that would directly impact the exchange and the individual market, and then I'll turn it over to my MIA colleagues to talk about what the impact of those provisions would be, we think, on the market, as well as to give an update on the recently released proposed rates for 2026. Next slide. And also say that Michelle Eberly sends her regrets. She's out today, or you'd be hearing from her. I'm sure you guys are all familiar with the federal budget reconciliation process, so I won't spend a lot of time on this. This is just a little diagram, but as I'm sure you know, the House passed the budget reconciliation bill a couple weeks ago. It's now with the Senate. They're starting to consider it. The President has said that he wants a bill on his desk by the 4th of July. And so we'll be seeing the Senate's actions over the coming weeks and if they're able to meet that deadline. So what we're discussing today is what's in that House bill that was passed. Next slide. So I have the provisions kind of grouped by category here in terms of their impact, from greatest impact onward. All of these are significant impacts, though. So the first set of items in the reconciliation bill would really increase the administrative burden for individuals to initially enroll, whether they're doing that during open enrollment or outside of open enrollment because they have a qualifying life event, and to renew coverage each year. So if you're enrolled, we will automatically renew your coverage at the end of the year. It's consistent with the way many employer insurance plans operate, because we know that if you force people to actively renew coverage, everyone's busy, people miss that deadline, and you really increase the chances that someone will slip through and accidentally wind up without coverage in the new year. So right now, the way that Maryland Health Connection and other state-based marketplaces in the federal healthcare.gov marketplace work is we verify your eligibility to enroll at the point of enrollment. We check both state and federal databases, including the Social Security Administration to check your immigration status, IRS to check tax records. We also check state wage data if there aren't IRS records available for you, and a number of other databases. So while doing that, we're both confirming that you're eligible to enroll on the exchange, and if you're applying for federal tax credits to reduce your premiums, that you're eligible for those as well. We've been doing that successfully for over 10 years now since we've been in existence. And it's really in many ways kind of a modern best practice process of doing these automated real-time database checks and trying to minimize the amount of paperwork. The House Reconciliation Bill would move us away from this automated process and require a lot more paperwork from individuals to verify eligibility, often, really duplicating work that we're doing already. And very significantly, it would prohibit automatically renewing people who are eligible for premium tax credits. Right now at renewal, we rerun all of those checks. We're again checking your immigration status, checking your income against state and federal databases. And then if you pass all those checks, we'll automatically renew you. The bill would prohibit that automatic renewal process. It would require everyone who's eligible for a tax credit to actively come in each year, starting in August, and review and kind of touch their application in order to be renewed. Right now, 75% of our enrollees do take advantage of automatic enrollment. So that's about 146,000 people last year who auto-renewed their coverage. So this is sort of an unprecedented proposal, but other somewhat similar experiences in other states, as many as 40% of people have failed to auto-renew when forced to come back and update their application. So, and of course, it's usually the healthiest people where this is least on their mind who are likely to slip through the cracks here. People who are sick are really paying attention to their dates and their notices and are more likely to jump through these hoops. So that's a concern that, the risk pool will get worse. The sicker people are going to be more likely to retain coverage and healthier people to lose it. And MIA will be discussing that more later on. Next slide. There are also a number of provisions that would increase the cost that people pay for their health insurance. Very notably, the bill does not extend the enhanced federal tax credits that sunset at the end of this year. So during COVID, the premium tax credits were increased by Congress. That had a tremendous impact on improving affordability for people. It also removed the cliff at 400% of the federal poverty level, meaning that no one, regardless of their income, has to pay more than 8.5% of income for a plan. So that particularly helped people in the 55 and up, more middle income bracket who can have quite high premiums there right before retirement if they're in the individual market. So those enhanced tax credits would revert back to the levels they were at before 2021, which means we estimate an average out-of-pocket cost increase for people in their premiums of about 68%. So, really a dramatic increase in that net cost after tax credits. So we had hoped against hope that Congress might take up an extension of these in the reconciliation bill, but to date, no such luck. The bill does change the way the premium tax credits are indexed in a way that is estimated to increase premiums for people who get those tax credits by about 4.5%. About 75 to 80% of enrollees on Maryland Health Connection do qualify for tax credits. So it's certainly the majority of our enrollees, although we are proud that we have that 20 to 25% of folks who don't qualify for tax credits and still find the value in enrolling on exchange. The House Reconciliation Bill would also allow plans to charge higher cost sharing while still remaining within the metal level categories that are federally set of bronze, silver, gold. So for example, right now, a silver plan has to cover between 70 and 72% of a person's costs when they go to use care on average. This would allow a plan to call itself a silver plan and cover as little as 66% of costs. So at each of those metal levels, the plans are able to cover less and increase cost sharing while still qualifying at that metal level. The House Reconciliation Bill would also eliminate caps on repayment of premium tax credits at tax time. So each year, people who receive these federal tax credits have to reconcile them against their actual income when they file taxes, because we grant the tax credits kind of prospectively based on their estimated income at the beginning of the year. They're also supposed to come back in and update their income during the year if anything changes. But because income fluctuates, people can end up having received either too much or too little tax credits, and that gets trued up when they file their taxes. Currently, there's a cap on how much you have to repay depending on your income level to particularly protect lower income people from having a significant tax burden. This would remove those caps, so everyone would be obligated to repay all excess tax credits that they receive. This is something that we already get complaints from consumers about each year who didn't quite realize this, and when tax time comes are surprised at what they're having to repay. So we anticipate that would increase significantly if those caps were removed. And then the last item here, which is pretty weedy, and I'll leave it to the Insurance Administration to get more into this, but it would refund federal cost sharing reductions, which affects the way the silver plan premiums are calculated in Maryland. And the end result of that would be a reduction in people's premium tax credits, as well as some other impacts to the state. Next slide. The bill also reduces opportunities to enroll and eliminates state flexibility to govern enrollment opportunities. So first, it would shorten the open enrollment period for all states from November 1st to December 15th. Currently, our open enrollment period is aligned with the current federal marketplace OE period, which ends January 15th. So the proposal would shave a month off of that. And currently states have the flexibility to set their own open enrollment dates. So although we choose to align with the federal government, we don't have to. This would remove that choice from states and force all states into the same open enrollment period. We see that about 40% of our enrollees enroll in that second month of open enrollment, or last month of open enrollment. And they tend to be a little bit healthier, folks who may be procrastinating a little bit and come in at the end. It would also, the bill, eliminate a special enrollment period that exists for people whose income is at or below 150% of the federal poverty level. This special enrollment period is really meant for people who are kind of fluctuating right around that Medicaid eligibility threshold and are, a little bit over income for Medicaid. It gives them more opportunity to get enrolled in the individual market outside of open enrollment. So if they miss their typical, say, 60-day or 90-day special enrollment period opportunity after they lose Medicaid, and they realize 4 or 5 months, post loss of Medicaid, they still can come into the marketplace because we have this, if their income is still at that low threshold, just over the Medicaid eligibility levels. We've had that special enrollment opportunity for a couple years now, and we've seen pretty strong uptake of about 1,000 people using it per month. So that would be eliminated. Next slide. There are also a number of provisions that would impact lawfully present immigrants, either removing their eligibility for premium tax credits or altogether removing their eligibility to enroll on exchange. So first off, I'll cover those who would still be eligible to enroll on exchange and receive premium tax credits, provided their income is over 100% of the federal poverty level. That group would be green card holders, COFA migrants, which are some residents of US territories, and a subset of immigrants from Cuba. Individuals who are currently eligible to enroll on exchange with premium tax credits, but would no longer be eligible for those federal tax credit would be all lawfully present immigrants with income under 100% of the federal poverty level, as well as at any income level, people with a status as an asylee, a refugee, or temporary protected status. So currently, a number of individuals are enrolled who are under 100% of the federal poverty level and are enrolled on exchange while they wait to become Medicaid eligible. There's a 5-year waiting period, for example, for green card holders before they can qualify for Medicaid. During that interim period, they're eligible for tax credits on exchange, and we see significant enrollment. We've got about 24,000 people in that under 100% of the federal poverty level getting coverage on exchange. If they lose the eligibility for tax credits at that low income, there's really no way they'd be able to afford to pay full price for coverage. So we expect that all of those individuals would become uninsured. Again, these are legally present individuals. So our estimated impact there is at least 24,000 people. The number is higher than that likely, but we're still pulling the data on that. In addition, individuals with DACA status who just became eligible to enroll on exchange and receive tax credits in 2025 would no longer be eligible to enroll on exchange. So the other individuals I mentioned could still come on exchange but couldn't get tax credits. Individuals with DACA status would not even be able to enroll on exchange. That's about 250 people who are currently enrolled who would be impacted. And then the last thing I'll mention here is a little bit different, but still kind of related to this overall topic, which is that the bill would reduce federal Medicaid funds if the state offers coverage to individuals who are not legally present. So the 90% match rate for the ACA expansion population is dropped to 80%, which is, of course, a significant budgetary impact. So for example, if the state were to move forward with the Access to Care Act legislation that was passed this recently and is intended to be implemented for 2026, that would trigger this Medicaid fund reduction as best we understand it so far. So that obviously kind of would force the state into a conversation about the fate of that legislation. Next slide. And then here are just a few provisions that impact Medicaid, but would impact Maryland Health Connection in terms of our operations and system. This is by no means a comprehensive list of the impacts to Medicaid because that's really for MDH. And I know they have been reaching out to provide explainers, but just a few things that certainly would impact our operations and require system changes. The requirement to put in place work requirements for Medicaid enrollees, which had initially in the House bill been proposed to go into effect in 2029. That implementation date was moved up to the end of 2026. So there is a whole suite of activities the exchange would have to work with MDH to implement in terms of notices and determining people's eligibility and application changes. So a lot that would have to happen for that. It also requires that the ACA expansion population have their eligibility redetermined every 6 months instead of every 12 months. So that more frequent redetermination cycle, which means running people's applications against the different state and federal databases that we use to check eligibility, that would happen more frequently, more notices, more calls, more consumer confusion likely to result from that. And then it would limit retroactive Medicaid coverage to 1 month instead of 3 months. Our system currently, allows individuals to select those up to 3 months. We would have to make some modifications to limit that to just 1 month, and many other Medicaid provisions, but just a few there, as I mentioned, that would directly impact the HVX system that we operate. So I think that's the end of my portion of the presentation, and I will turn it over to MIA.
So, and thank you so much for your presentation. Give Michelle Everly, on behalf of the Finance Committee and ACO Committee, our love. She's a really amazing partner, always works with us. For the members of both committees, we're going to wait to ask the questions at the end. There's actually 2 more presentations, and then we'll open it up. I want to thank you for coming, the members, and making the time to be with us, okay? Next, we have Marie Grant, who's a commissioner for the Maryland Insurance Administration. Good afternoon.
Good afternoon, Madam Chair and Chair Beidel. It's great to see you all. Brad Bobin, who's our chief actuary, and I are going to be talking about first an initial look at our individual ACA rate filings and small group market rate filings. And then we're going to talk a little bit about the impact of many of those provisions in the bill that Johanna just talked about. I just want to emphasize to everyone the fluid environment and the hard job that I think our actuaries, as well as company actuaries, are going to have this summer working with the exchange too on the state subsidy that we have to try to mitigate some of these impacts. But it's going to be a really fluid situation. We'll talk through the reasons for that. Here, next slide. Okay, so first of all, so we did receive our rate filings. We published those this week. And for health insurance rate filings for our major medical coverage, we have prior approval, and state law says those rates cannot be excessive, inadequate, or unfairly discriminatory, and must be reasonable in relation to benefits in the context of healthcare. Otherwise, we are required to disapprove or modify a proposed premium rate filing. And I want to emphasize here too that every year we usually cut the carriers down from what they're asking. We really do challenge their assumptions. We ask a lot of questions, and we get to a place where we think what they're asking for is reasonable. So the next few bullets sort of talk about the things that our actuarial team look at. They look at experience, they look at past year's claims, they obtain analyses from carriers. They review the assumptions that need to be both supported and reasonable, both individually and in aggregate. And so this next bullet talks about some of the key assumptions that we're seeing in these filings across our carriers. They include claims trend, so both the cost of services as well as the utilization frequency. Morbidity, which is the relative health status of the pool, and we'll be talking about that more because that's really important in individual and small group. Operating expenses, profit margin and contribution to reserve, risk adjustment transfers, which is a really important component of how the individual market works. Reinsurance recoveries under our 1332 waiver, which is a state-federal partnership that helps to improve affordability on our individual market. And then the impact of proposed federal legislation and regulations. Next slide. Okay, so this is the timeline that we are going to be working with over the summer. So some key dates on our end are that we received our rates filed with the carriers May 19th. We've published those. And in the meantime, MHBE in consultation with our actuarial team, is working to design a state-based subsidy that was authorized by legislation that you all passed. So I think we are concerned that enhanced APTC were going away. We didn't see progress on reauthorization. The General Assembly passed a law that allows us to use some of the funds that are in a special fund to design a subsidy to help mitigate those changes over the next 2 years. We're probably not going to be able to replace that. We are going to be able to mitigate that. And so that will impact the rate filings that we see. The next MHB board meeting is July 21st. We're having our public hearing where the public is, carriers will present on their rate filings and the public is invited to comment. Our deadline for public comments is August 30th, and then we need to approve rates by September 5th in order to get those rates over to the exchange to get notices out to consumers in advance of open enrollment. Now, underlying all of that, I think, is the federal reconciliation debate, as Johanna noted. There's a number of provisions in there that would impact our individual market. There's also a number of provisions that take effect for the 2026 plan year. And so I want you to sort of pin that thought in the back of your head. I'm going to turn it over to Brad Bobin now, who is our chief actuary and is going to go through some of the filings we've seen in some more detail. But once Brad's done, I will take over again and talk about, again, some of the detail of what we are seeing in this bill and what it could mean for our market directionally.
And thank you, Commissioner Grant. Thank you for your partnership with both the Senate and House committees. Brad, good afternoon. How are you?
Good afternoon. Good, thank you. Thank you for having me here today.
Thank
So what's been filed so far in 2026 for the individual ACA is an average of 17.1%. This is the highest increase we've seen since 2018, since before the reinsurance program was put in place. The average is 17.1, but it ranges from 8.1% to 18.7% by carrier. Carriers have filed alternative sets of rate increases that would represent what would happen if ARPA would be to extend, and that set of increases is an average of 7.9%, with most filings between 5 and 7%. An important note is that Aetna is exiting the market nationwide in 2026. They're exiting all their individual markets. So that's going to impact about 5,000 members in Maryland who are going to have to choose a new plan. Overall, the pricing trend for the individual market is 6.4%. This is 4.9% on the medical side and an 11.9% drug trend. And then finally, morbidity is the main driver of that 17.1% increase. Carriers are projecting an enrollment decrease of about 19% from the 2025 record level. They're projecting that the healthier members are going to be more likely to lapse, leaving behind a risk pool that's approximately 10% sicker, according to their projections. And so that's the impact for just the ARPA subsidies expiring. It doesn't include the impact of all the other House reconciliation bill components. Next slide, please. So as we have already talked about, these enhanced premium tax subsidies were originally passed under the American Rescue Plan. They were extended through the Inflation Reduction Act. They end in 12/31/25 without any congressional action. They both increase the amount eligible for those already receiving taxes, as well as expand the number who can receive by removing the 400% cliff. And so right now there's no limit to the income where you can receive a tax credit, as long as the second lowest cost silver plan would be more than 8.5% of your income, then you're eligible for a tax credit. So we're seeing people up to 500-600% FPL get tax credits now. Since May 2021, when the tax credits were first enhanced, Maryland's seen over a 50% increase in the number of those receiving tax credits, from 126,000 to 190,000. Next slide, please. So this shows the impact of the tax credit for a sample person, at various FPLs. And so the FPLs at the left of the page are percent of federal poverty level. So at 150% FPL under ARPA, they're paying zero. They've got a $0 premium. And under the original ACA, they're going to have a $65 premium. 200%, they're going to go from 45 to 137. That's a 200% increase to that $45 premium. And so you can see how the impact varies by the income level. And then you can see at 401% how the cliff re-emerges, how under the original ACA, there is no subsidy. So that person that pays $386 under ARPA is going to have their premium double up to $782 as the cliff reappears. So this is a sample of what's going to happen because of these ARPA subsidies going away. As Johanna said earlier, the average increase is going to be 68%, but it's going to be especially bad for those at the lower incomes and those just over 400%. Next slide, please. So this shows the detail of what's been filed for the individual market by carrier. Some things to note on this tab are, the enrollment picture for 2025 is really good. We're up 10.4% enrollment from the previous year, up to 296,000. That's a record for on and off exchange enrollment since the ACAs began. We're at the highest level ever. And then you can see the rate history in green. And you can see from 2019 to 2021, we dropped rates by 31.4% when we first implemented the reinsurance program. Those first 3 years saw the big decrease of the rates. And then for the next 4 years, we've had low single-digit increases, reflective of trend. And now this year, we have the 17.1% increase. And as I said, this is driven by the ARPA subsidies expiring. You can see that by carrier, it varies. WellPoint is only at 8.1%. They're a small portion of the market, whereas CareFirst Blue Choice, the HMO, is at 18.7%. They're a much larger portion of the market. United is at 18.6%. So, that's why the average is at 17.1. Next slide, please. So on the bright side for the individual market, decrease of 1.3%, and 60% of policyholders are going to be receiving a decrease for dental. Next slide. And this just shows that detail. You can see that there is a range. One dental company, Dominion Dental, is asking for a 2.2% increase, but the decreases on Alpha and CareFirst are bringing the average down to minus 1.3. And also, I'll note that there's over 100,000 enrolled in these dental plans now, which is not up as high as medical, but still shows continued growth in these individual dental plans. Next slide, please. So in the small group market, the carriers have requested an average of 5.5%. That varies by carrier from 3.3% to 12.2%. In the small group, the major driver of the rate increase is trend. Average small group trend is 6.9%. With 12% prescription drug is the main service category driver, just like an individual. And then there is a 10% enrollment loss in small group, but the morbidity is stable, implying that the groups that are leaving the market are not healthier than average. So that's different than the individual, where we're seeing the morbidity increase because the healthier are leaving the market. And we're not seeing that morbidity increase in small group. Next slide, please. So this shows the details of what's been filed For small group, the 5.5% average. It varies by quarter in the small group market. And like I said, it varies from a 3.3% for Care First Blue Choice, which is 70% market share, up to a 12.2% for one of the United companies. Um, and this is a little bit higher than what we approved last year. We approved 4.5% last year. This is a little bit lower than we approved 2.2 years ago at 6.9%. And you can see the enrollment here. There's minus 9.6% enrollment. The enrollment dropped, to a little over 205,000 members. Next slide, please. Okay, I'll turn it back over now to the commissioner.
Thanks so much, Brad. All right, so if we can move to the next slide, please. Wanted to give an overview of I think some of the provisions that Johanna gave an introduction to, but how they may impact directionally the market as we're entering in this rate review season, and some of the things we're going to need to be thinking about depending, again, what happens at the federal level. So the American Academy of Actuaries actually submitted a letter to the House and Senate a couple of weeks ago that highlighted some of the provisions in that reconciliation bill that have the potential to discourage enrollment and adversely impact the risk pool. And as Johanna was saying, if you make it harder to enroll, or folks have to jump through more hoops, the folks who tend to have health needs are going to be the ones that want to jump through those hoops, right? I think our younger, healthier folks might tend to step away then. And so this is a concern, I think, that actuaries have flagged about some of these provisions. So first of all, reducing the open enrollment period to 45 days nationwide. This is really, we have, I think, and Johanna can keep me honest here, always had the flexibility to set our open enrollment period, as well as to design special enrollment periods that make sense for Maryland and make sense for our market. This became, I think, particularly important during COVID when we were able to react quickly. And so this piece of legislation would instead say, no, it's 45 days. We're going to enshrine that in federal law. That's it. There's new special enrollment period verifications that would be required on our marketplaces. And I just want to emphasize too, there are verifications that exist already. This would set new higher standards. It would require income verification for all marketplace applicants, including those enrolling during open enrollment. And that's not, again, that's not to say that those don't happen already, but this would present some new burdens and timing challenges. And especially as you think about, and I think what our team is thinking about is like, how do all of these provisions work together? And so when you're talking about these kinds of additional verifications in a shortened open enrollment period with fewer opportunities for a special enrollment, if your life circumstance changes, you can see that they all add up and could result in potentially barriers to coverage. There's a prohibition on premium tax credits for individuals who didn't file an income tax return or reconcile in prior year advanced premium tax credits. And there's also a provision that removes caps, as Johanna talked about, of removing caps on consumer liability for repayment of excess advanced premium tax credits when actual income exceeds estimated income. And I believe it doesn't change the overall liability. I think what we're talking about is the timeline for repayment as well. Okay, next slide. Okay, so some of the additional barriers that are in the House reconciliation bill for marketplace enrollment. So there's an elimination of automatic or passive enrollment, meaning all advanced premium tax credit recipients have to take action starting in the 2028 plan year to ensure that they stay in the market. And I know sometimes at first glance, we might say like, well, what's the problem with that? Well, if we think about how we all enroll, I know I'm in a county plan, for example. Some folks may be in the state plan. If there aren't major changes, a lot of us do passive enrollment every year. And so the same thing happens in the exchange, and you know, it could become a real barrier to coverage again with the concern about the shortened enrollment period. The bill also eliminates some provisional eligibility for premium tax credits and cost sharing requirements during resolution of data matching issues. And these happen, I think, far more often than folks might think. It might be folks who have sudden changes in income. That could be families with newborns, people who are getting married and divorced, people losing their jobs. Again, like if there's a big change in your life that results in some differences in data and what's on file with the federal government, then this could delay eligibility for premium tax credits and again, like harm folks' ability to afford their health coverage. Next slide. Okay, so I'm going to talk about, and this is a wonky provision, so bear with me for just a second. But the ACA allows for plans that provide subsidies for cost sharing for lower income individuals. And what that means, so addition to the premium tax credits, if you are of a certain income, there is support for out-of-pocket expenses like copays and deductibles. And in 2017, under President Trump the first time, the administration, through administrative action, said we are not funding carriers for these cost sharing requirements any longer, which created a situation that states then had to address to maintain individual markets, because carriers are required to offer these plans that have cost sharing help, but then they weren't getting cost sharing payments from the federal government to support it. And almost, I think there may be a couple of states that don't do this, but the vast majority of states, maybe all of them at this point, do something called silver loading to address this issue, where we load the cost of the CSRs into a certain plan. And what that has ended up doing, ironically, is unfortunately, it has caused the federal government to spend more money because it's raised the value of subsidies. But that is now the way it's been since the 2018 plan year, and it is an assumption under which our markets operate. So the House Reconciliation Bill appropriates funding to so essentially which would give money to insurers to do this, but then would also change the way that we've been doing silver loading and calculating subsidies in our market. It also prohibits plans that cover abortion care from receiving CSR reimbursements. I think there's some ambiguity in what that could mean for states that require plans to offer non-height abortion care, like Maryland. But what we think could happen if this language were to pass was that the federal government would direct, say, Maryland, just because you don't get CSR payments for your plans, that doesn't mean you can silver load. So I'm making a jump, but we think that's what it may mean. And so that might be a conversation we have to have. We'll see if that provision survives what they call the bird bath and whether it's a budget or a policy provision. So if silver loading were to end, it would result in reduced tax credits for low-income consumers for bronze and gold plans, just based on the complicated interactions I was talking about. It would also lower pass-through dollars for our reinsurance program over time. And so the extent of that, the value of that, again, is all things that we are looking into, but it is a dynamic and a provision we wanted to highlight. Next slide. Okay, so these are some preliminary estimates from the Kaiser Family Foundation on what, and I want to emphasize some, not all, some of the provisions in the House Reconciliation Bill could mean for Maryland. And so again, it's taking a Congressional Budget Office estimate and then allocating it among states for just some of those provisions. But one estimate for, and this is our increase in Maryland uninsured by 2034. And for context, I think the current uninsured number is somewhere around 380,000 folks. So with just some of the provisions, we would talk about potentially increasing our uninsured rate, all other things being equal, by 100,000 to 160,000. And then if you combine that with the expiration of the enhanced APTCs, we're talking about by 2034 an increase of 120,000 to 200,000. All other things being equal, right? So not taking into account anything we might do as a state, any other provisions, but then the bad news is that doesn't include some of those really, those provisions that we are concerned could have some impacts on the markets. So, okay, so I think I have shared enough doom and gloom. I will say as we get into questions, that my team and Michelle and working with Michelle's team are certainly dedicated to being as creative as we can to figure out how to support and preserve our markets, both individual and small group, under active conversations, but definitely appreciate the opportunity to share with you what we're seeing in this bill so far and sort of directionally how it could impact our markets. And I think if we want to go to the next slide, I think it's a question slide.
Well, I want to thank you for giving us this very depressing news because it's not your fault, right? It's the federal government, and we have done so much in Maryland to make sure that we didn't get here, right? To make sure that people have insurance and to reduce the number of people without insurance so that they don't end up in the hospital, right? To make sure we keep the community healthy. But I thank you in advance for the work that you're about to do. And you know that we are a partner. And so count us, count on that we will work together to find solutions. I'm going to open it up for questions now. Will you be so kind and just raise your hand? And when I see you, I'll call on you. And I'm looking through the number of participants. And this is the opportunity that you have to ask questions. Delegate Hill, followed by Delegate Szeliga.
All right, so thank you all for the presentation. What I find missing, and maybe it's because you can't speculate on it, understand that the House Reconciliation Bill and some other actions also are going to impact EMTALA. So I guess what I'm trying to get a sense of, if what you've presented is that we're going to go back to the good old bad old days of having many people who are uninsured, meaning that we're already behind in ER wait times and providing that care. And if at the same time we're going to tell hospitals they don't have to provide that care, essentially, I need you to make clear to me and state aloud, what would we be actually doing in terms of telling people who get sick without insurance they can do here in Maryland?
Yeah, Delegate Hill, oh, sorry, was someone talking?
Sorry, Commissioner, go ahead.
Yeah, that's a great question. I want to say to be continued because I think you're bringing up an excellent point of how these provisions could interact with other provisions. We obviously, the state Medicaid agency is not here today. There are certainly many impacts on Medicaid. I think should this bill pass in its current form, there would be big conversations we would need to have as a state. But I do also want to emphasize that, but this bill has not passed yet, right? It is going to undergo major changes in the Senate. I think we want to be as transparent as we can about the impacts of what we are seeing, to make sure that we're helping to inform folks along the way. But I think you raise an excellent point. The answer is I just don't know yet. I can't speak to the total impacts yet.
All right, thank you.
I have Delegate Shilega, followed by Delegate Taveras.
Thank you. Thanks for the presentation. I guess I have two questions. The first would be, it sounds like what is going on here is returning to pre-COVID subsidies, pre-COVID, during COVID subsidies and things were changed because of COVID. And is this correct that the federal government is going back to what it was pre-COVID?
Yeah, absolutely. Yes, Delegate Shilega. So it's not the total loss of the subsidies, to your point. It is the loss of the enhanced that have been in effect for at least 4 years. Yeah.
Yeah, and I think the rationale I've heard from Washington is that COVID's over. So we're going to go back to pre-COVID. Brad, could you go to slide 14 for me, please? Thank you so much. So I heard you say something about 500 to 600% of FPL when you were talking about this slide, but I don't see it listed here. Are people, what is a number that 400, we'll pick 400% of federal poverty level. What is that amount that somebody can make?
I believe that's $63,000 or so for this year, for 400%
for a single person.
For a single person, yeah.
And for a family, what would 400 be?
It would be $128,600.
Okay, so if we just look at the federal poverty level, their original without the enhanced COVID was 413. They're going to see a $28 increase, and that would be taking into account a 5-year time difference. So, I mean, obviously we've had inflation and all kinds of stuff. Is this just kind of like flat data?
Yeah, at 400%, it's only a $28 increase. That's only 7%. That's the lowest on the chart. But yeah, that's how to interpret
And
this.
I didn't pick that out intentionally because it was the lowest. I just was like, 401 just didn't make sense to me. Okay, so someone who's making 500 to 600% federal poverty level, are they getting subsidized?
Depending on who they are, yes. Right now, under the enhanced subsidies, they're eligible for subsidies. But when things revert to the original ACA subsidies, they'll no longer be eligible. There will be a cutoff of 400%.
Okay, so if it's 500% must be like a family of 4 making 160,000 a year. I'm taking a wild guess. And obviously 600% is much higher. So obviously, these COVID provisions were put into place to help people because of income uncertainty. But, some might argue, myself included, that, subsidizing families that make that much money, is something that we should look at going back to pre-COVID. So it sounds like finally, I would just say that, the 45-day enrollment period that these potential changes would return to is actually longer than what the Maryland state employees get. Is that right? Because I think I looked it up. Maryland state employees have about 3 weeks or 4 weeks to re-enroll in their health care. Is that right?
Delegate Schlega, that sounds right to me, but I think uh, again, so a couple of things, maybe a couple of differences between the state employees and the exchange. The exchange, you do have to go through income verification with the exchange. And you know, there are concerns about so it's like the 45-day open enrollment plus the other changes, right? So the process too of enrolling may not be as seamless as the state employee plan is.
Yeah, it does
Yeah.
look like there are more requirements, but could you satisfy the income verification by providing your tax returns?
Johanna. So yeah, I'm
I
gonna
think
defer
we're-
to MHB on the process.
I think
Yeah,
those
I think-
details are probably still
Yeah.
to come from the federal government.
Yeah, so, okay, I'm just making a point here that, you know, we're giving state employees half the time that we're, you know, doing, although, you know, it's important to note that there are more qualifications for people getting tax subsidies to help taxpayers help pay for their health insurance. So anyway, thanks again. And once it passes, I'm sure we'll have another briefing from you guys. I appreciate your time.
Thank you very much. Delegate Taveras, followed by Delegate Bagnall. You have to unmute yourself. Delegate Taveras. I'm gonna go on to Delegate Bagnall while Delegate Taveras.
I'm here.
Okay, go ahead.
Okay. No, thank you. I don't know. I obviously we think about what's happening differently given that compared to Delegate Shalega, because you know, I mean, not only has my county, but the statewide, we've been economically downgraded given a negative economic outlook. That doesn't just happen, despite all we did to try to prevent that. So it's not like things are looking rosy here. And my understanding is that the Maryland Health Benefit Exchange is not necessarily for federal workers as much as for people who may be working independently, small business owners, people closer to the poverty line. Is that not correct?
Commissioner Grant.
Yeah, that's correct, Delegate Taveras. That's exactly right. Those are often the folks who are people who are just starting a job or in between jobs or are entrepreneurs. That's exactly right.
So this is concerning with regards to what's being proposed. My concern is that is the government using AI to make these automatic approvals? Because we do know, we've already seen the problems that AI has produced in generating inappropriate or false or, you know, ¿cómo se dice? Denials that people have to go the extra mile to go back in and try to rectify these issues. And it takes a lot of time and effort that a lot of these people don't have. So do we know?
So right now, the exchange is not using AI for these kind of income and immigration verifications. We're really just taking the data that people input in their applications for coverage and comparing it against data in federal or state databases to see if it matches or if income's within a certain range. And based on that, we say, looks like everything in your application matches up, or we see something looks different. Please give us some additional information.
No, I agree with you. Like that's how we are doing it now. But I'm nervous that in the future, given all these recent changes, all these recent firings, and making the timeline that we're revisiting these applications every 6 months. I mean, with the shortening of staff, you're not going to have that kind of time.
It will certainly be a challenge to perform the level of verifications for the state that are contemplated under the House Reconciliation Bill. It's going to be a significant challenge for our resources.
Thank you.
Delegate Bagno.
Thank you, Madam Chair, and thank you for this presentation. And you know, I appreciate my colleagues' comments, but I know that we can't go back from COVID, right? We can only go forward. We had a major health crisis, which continues, and there are people still dealing with long COVID and the financial impacts of COVID. But if I'm understanding this presentation, it sounds like there are significant changes from pre-COVID. There's changes to data matching, auto enrollment, possibly losing passive enrollment, the redetermination processes, changes to the enrollment period, which requires an educational element, a reduction in funding and federal funding for state coverage of certain people and certain services, regardless of who pays, and an elimination of retroactive coverage. So I'm just wondering two things. One, do we know what the overall impact would be, given that there's been a reduction to the IRS and other federal agencies on what that redetermination process would even look like, and being able to do the data matching with tax returns, and also that 8.5% is that indexed to inflation or cost of living, or is that just based on gross income, regardless of how cost of living has changed since the pandemic?
Who will be the best person to answer that question?
Maybe I can speak to the IRS
Thank
portion
you.
and then hand it over to MIA for the other questions. So it is a concern, IRS staffing, and whether that's going to support even just the level of verifications that we do now, let alone kind of changes going forward. We have seen in other times of stress, like during COVID, that the IRS was not able to keep up with processing tax returns in a timely way, and it presented challenges when we were trying to ping their database. So we are concerned about the IRS having the resources they need to continue to be able to timely provide data to us going forward.
Maryland Insurance Administration.
Yeah, on the next question, so the enhanced ARPA subsidies tie the availability of subsidies to folks to sort of ensure that they don't pay more than 8.5% of their income for a benchmark silver premium. And Johanna, please clean me up. Brad, please clean me up, because this starts to get highly technical. So where that often comes in, and where we see the higher income folks, like if we're getting into 500 or 600%, why those folks may be receiving subsidies, it's typically because they are on the older end, like their pre-Medicare eligibility, they may be in their 60s. And the cost of their premiums, because everything in the individual market is age rated, they're very high. So I think, so for example, on the slide Brad showed, the unsubsidized premium for that 64-year-old in the metro area, I believe, is over $700 a month, and that's because it's age rated. So that's where that's how the ARPA subsidies are designed, is for those folks. So there's not just like a hard cliff above 400% of poverty.
Losing those extended tax credits could have a significant impact.
Yeah.
Okay, I have Senator Lamb, followed by Delegate Bandari.
Thank you, Madam Chair. And, you know, this is a very sobering presentation, obviously. I think we're facing a huge cliff of the number of Marylanders that are going to be losing their insurance. It's going to be a tremendous amount, which I think is going to be difficult for all of us. I think, you know, to the earlier point of it moving back to being pre-COVID days, and I think Delegate Bagnall also touched on this as well. This is a much deeper rollback than that. I think there are not only provisions that pull it back before COVID, but there are provisions that also limit the ability of the state to put forward some really innovative insurance mechanisms to help increase enrollment for folks. And so this is not just a pre-COVID rollback. This is a prehistoric rollback of our ability to be able to get as many Marylanders insured as possible, which is obviously very concerning. And even to the point of, state employees being able to, state employees having shorter enrollment periods. State employees don't have to go through auto-enroll. They can go through auto-enrollment. They don't have to go through all the hoops of re-enrollment, redeterminations every 6 months. And so there's some really big differences here when you look at what's being proposed, and hopefully this won't come to fruition, and what we've been used to during COVID, but also even what we've been used to in having the flexibility as a state to do that before COVID too. And the impact could be hugely significant for us. The question that I had, I guess, was with regards to special enrollment periods. And I'm wondering, a couple of years ago, I passed legislation that recognized that becoming pregnant was actually a qualifying life event, triggering special enrollment, not just giving birth. So that was actually able to get more women insured earlier so that they could get all their prenatal care and the like. Will any of these changes that you're aware of impact the state's current special enrollment for those who may become pregnant, or those who become pregnant, versus like having to wait until they're actually giving birth and delivering?
My understanding is that it would not prohibit the state from continuing to offer that special enrollment period to pregnant women, but they would be subject likely to additional verifications. So as we were discussing, the additional administrative burden of doing some additional income verifications before they could get premium tax credits would apply to them as it would apply to people enrolling for other special enrollment reasons. So we could see people just having more administrative challenges to getting enrolled and it potentially taking a longer time.
And what about the impact to like legislation that the chair and I worked on and passed with regards to the Healthy Babies Equity Act? How would that be impacted at all?
I'll maybe let the commissioner answer that one.
Well, and I think I can give you a little bit of a preview, Senator Lamb. I think it is more a conversation for the department because it leverages our Medicaid program to provide that coverage. I think that is a provision that they're looking to understand how it would impact their abilities to continue offering that coverage.
Right. Yeah, no, I'm certainly concerned about that. That would be devastating to many pregnant women that need health insurance. And I know the chair and I have been looking back and recognizing thousands and thousands of women have been able to qualify for health insurance under the Healthy Babies Equity Act, and having that unwound is just devastating to many of these women, their families, and ultimately to these young Marylanders. So very concerned about that, and just say that, at the end of the day, I think this is, while we're seeing these immediate concerns here that are affecting certain people's ability to be able to enroll and re-enroll in health insurance here in the state of Maryland, that it goes beyond that it affects all of us, because there are people that, even if they're uninsured, can still get health care by going to our emergency departments, using those pathways to be able to get the coverage that they need. And so it's going to exacerbate our ED wait times. It's going to lead to more uncompensated care, which is going to drive all of our health insurance premiums up, because it's going to, we're all subsidizing the folks that don't have health insurance through our own premiums. And so, I think that particularly the insurance commissioner probably can recognize this, that the potential is there to drive up the insurance rates for all of us across the state, even though we're talking about the immediate concerns that affect, these hundreds of thousands of Marylanders themselves.
Yeah, I agree, Senator Billy.
Okay, Delegate Bandari.
Thank you, Madam Chair. Commissioner Grant, on slide 23, you note that ending silver loading would reduce tax credit for bronze and gold plans and lower pass-through funding for Maryland reinsurance program. What analysis has been done on how this would impact enrollment and affordability for low-income Marylanders? And are there legislative options we should be considering to preserve affordability if federal CSR funding is reinstated under these new conditions? I know that we have passed a lot of good bills this year too.
Yeah, thank you, Delegate Bhandari. So I think we're still looking at the impacts. I'm hesitant to share impacts today that have dollar or an enrollment impact. I think we're still looking to understand that amidst, again, the context of all this legislation. Again, it's my hope that some of these provisions that we're seeing that are really concerning to our marketplace as may be amended out. I think there's still opportunity for the Senate to do that, but we're going to be keeping in really close touch with you all, to your point, so that if there are things that we can do through state legislation to address some of those dynamics, we'll definitely be keeping in touch about that.
Thank you.
Delegate Rosenberg.
Thank you, Madam Chair. Is a calculation of the cost of implementing being made by either the executive branch or the legislative branch staff? Is that calculation being made now, or are they waiting for the final bill? What it would cost us to continue to provide coverage in light of these various changes?
So I
That's
think
my question.
Yeah, Delegate Rosenberg and Johanna, I am speaking only for the marketplace for the markets I regulate, and then would want Joe Hamid to chime in on the exchange. We're looking really closely at the impacts, both enrollment and cost, for each of these provisions. We're just not in a place where we can really share that information today, but we are definitely looking at those. Johanna, do you have anything you want to add there?
Similarly, we're working on modeling that state subsidy to mitigate the loss of the enhanced tax credits. So that will have a cost impact to our special funds. And then we're also in the process of trying to put together some estimates for implementation costs for the exchange if we were to implement all of these provisions, but that's ongoing work for us.
Thank you.
Are there any other questions? I'm looking through all the delegates and senators present to see. Make sure I do not miss anyone. And I do not see any other questions from anyone, but I do have a couple of questions that I have for you, Commissioner, if I may. When I look at these proposed provisions, it's not just pre-COVID then, right? Because there are a lot of different provisions in this big awful bill. And the first one, tell me, what happens when you reduce opportunities to enroll and you eliminate state flexibilities? Johanna, what happens when you do that?
Well, we're likely to see enrollment decline. And as the commissioner and Brad mentioned, when it's more challenging to enroll, it's typically those individuals who need healthcare who are more motivated to work through the challenges to get coverage. So that impacts the health of the market and the rates that everyone is paying. And then when you reduce state flexibilities, as the commissioner alluded to, you affect the state's ability to respond to unexpected circumstances. For example, during COVID, we extended our open enrollment period for nearly a year to make sure that people could get in and get covered. So when there's other kind of unexpected events that arise, it limits our ability to respond.
What happens when you do not extend the enhanced federal tax credits if they were to sunset in 2025? If you do not live in Maryland, if you do not live in Maryland, what happens? And what did we do by being creative?
So if you do not live in Maryland, there will be an increase in your rates, likely due to morbidity, and folks will drop coverage or lose coverage, either because they are not as motivated to pay for coverage or because they can't afford that. We're really grateful to the General Assembly for passing HB 1082, which allows us to design that state subsidy. to help to mitigate those impacts. And so I think we're grateful to have that opportunity. Unfortunately, the opportunity is set against some additional challenging dynamics at the federal level.
And what happens when you limit retroactive coverage to 1 month instead of 3?
You may see a rise in uncompensated care.
And what happens when you have uncompensated care?
It drives folks' premiums up.
And what happens to the emergency rooms?
And I think there's been some concern expressed that we could see overcrowding in emergency rooms where folks try to seek care there because they can't afford care in the appropriate setting.
What happens when you're uninsured and you don't have insurance and you're sick?
You may delay care until it's a bigger issue and it's more expensive.
Are you concerned about these proposals?
Yes, very much
Why?
so. I'm concerned about these proposals because I am concerned about their impacts on the affordability for comprehensive coverage for Marylanders. And I'm also concerned about Marylanders' ability to access coverage when they need it and additional barriers being thrown up.
And what happens when now our uninsured rate is 6%? And before we did, and we were creative and passed all these laws to reduce that number, which was 14%, it would take us backwards, wouldn't it?
Those are the projections I'm seeing.
Thank you. I don't see any other questions from anyone. My co-chair, Chair Vital, do you have any final comments?
I'm just hoping and praying that the Senate doesn't pass the big, beautiful bill that the House passed, and that we are able to continue to help people with their health care, which, as I said the other day, I think, to me, providing health care to people is like providing food and water and education. It's a basic need. And I just really hope that we're able to not have the changes that the House bill is projecting. So, Commissioner Grant, I'm sure you'll keep us informed as we go along the way, and maybe see what the discussion is on the Senate bill. And I'm not sure what we can do other than wait to see what the Senate does. But thank you very much, Delegate or Chair Penny-Melnick.
And thank you, Chair Vital. Thank you, everyone, the Maryland Insurance Administration, the Health Exchange, for the work you do. And we are very grateful that you are at the table because you care. Everyone, thank you for your time and have an amazing evening.